Welcome to the section on nutritional assessment. When we begin talking about nutrition, we're going to talk about some of the things that are involved in the process of figuring out if somebody is malnourished or has appropriate nutrition. Some of the people that do this in the medical setting are nutritional care providers or registered dietitians. So the nutritional care process refers to the systematic approach used by registered dietitians to identify, diagnose, and treat nutrition-related problems or disorders. There's usually four components of this. We've got nutritional assessment, a nutritional diagnosis, we then have an intervention, and then we monitor the treatment and evaluation of this process. The nutritional assessment is the systematic process of obtaining, verifying, and interpreting data to make a decision about the nature and cause of nutrition-related problems. If you think about it, there's many different diseases that could potentially cause a nutritional issue. You could have somebody with a malabsorption problem in their intestines. They could have diabetes. They could be an elderly person that just doesn't eat enough calories. There could be a number of socioeconomic issues. Maybe the money isn't there for the proper nutrition, etc. So it's up to a registered dietitian to figure out what the problem is and try and treat the disorder by providing a new plan. When the registered dietitian goes through a nutritional assessment, they look at many different things. The assessment has a letter of A through E for each section. You will not be required to know this for a test, but I just thought it was kind of interesting, so I kept it in here. A is for anthropometric or body composition measurements, taking that body fat analysis. B is for biochemical analysis. What about the blood tests? How does their cholesterol? What about their albumin? Other things like that. C is for the clinical examination done by a physician or other healthcare provider. The D is for the dietary analysis to look at the things that the person is actually eating. And E is for an environmental assessment. Are there factors affecting the ability to purchase, prepare, or consume food? Which is where I put in that socioeconomic factor. One of the things that we see and can find after doing an assessment is somebody with metabolic syndrome. This seems to be a pretty common problem in the United States today when you hear on the news that we have this obesity epidemic occurring. This is something that is quite common. You are considered having metabolic syndrome if you have the following: an elevated waist circumference of a waist larger than 35 inches in women, or larger than 40 inches in men, a triglyceride level of greater than 150, a fasting glucose greater than 100, an HDL less than 50 in women, less than 40 in men, and a blood pressure of greater than 130 over 85. If you have this list of items, you're considered to be in the metabolic syndrome category, and it would be in your best interest to try and increase or improve these factors. Some of the biochemical markers that physicians and registered dietitians look at include macronutrients and micronutrients. I'm going to start off telling you about the macronutrients. These are the large things that you can see on your plate and that we eat on a day-to-day basis. The average daily macronutrient breakdown should be about 31% protein, 26% carbs, and 43% fat. Now, those numbers may surprise you, but if you have a high number of healthy fats in your diet, it is actually quite beneficial. So let's look at each of these macronutrients. First one is protein. It's your typical chicken, steak, eggs, things like this. These are ideal proteins, but they have a short half-life, and we can see changes in the serum depending on diet. The markers are affected by protein malnutrition. Sometimes there's end-stage liver and renal disease, severe infection, and stress injury. Those can affect the total proteins in your blood. Another one which we've talked about in the past is albumin. If somebody has issues with their albumin levels, it can help identify chronic protein deficiency under conditions of not having high enough protein calorie intake. It also identifies caloric insufficiency without protein insufficiency. So if somebody doesn't have enough calories, they may be thin, but they'll have enough albumin. If somebody does not have enough protein and they have a caloric insufficiency, their albumin levels may be affected. Transferrin is a protein that we've talked about many times in the past. This is an early indicator of iron deficiency. We see transferrin is actually increased with iron deficiency. He actually carries the iron around the body. We can see morbidity and mortality if these levels are off kilter. The next one is called transthretin, more commonly called prealbumin. Prealbumin effectively demonstrates an anabolic response to feeding. It's a good marker for visceral protein synthesis in patients receiving metabolic or nutritional support. So if you have somebody on tube feeding or IV feeding, we need to make sure that the proteins you're giving them in the IV solution or the tube feeding solution are turning from that protein into a usable protein in the human body. If that process is in fact going well, we'll find prealbumin levels to be normal. Retinol binding protein. This can monitor short-term changes in nutritional status. So if someone's diet is changing, we can figure that out very quickly. Insulin growth factor 1. These levels are regulated by growth hormone and nutritional intake. We can use it as a nutritional marker in adults and children to see how growth hormone and nutrition is within that individual. Fibronectin are levels that we see decrease after damage caused by shock, burns, or infection. It's not usually a nutritional marker, but it's something that we can use to monitor if somebody does have severe shock or burns, that they are in fact improving or getting worse. Nitrogen balance isn't a test that's very widely used, but it can be a good way to indicate protein change or the adequacy of feeding in a controlled setting. So if you are giving somebody X amount of protein via tube feeding or in an IV, you want to make sure that the excretion of nitrogen is equivalent to what is going in. You don't want to have your body not using it. You want to be able to use it in an adequate fashion. C-reactive protein we've talked about many times. This one is a marker of inflammation. So it's an acute phase protein that increases dramatically under conditions of having sepsis, inflammation, and infection. So it doesn't tell you exactly what's wrong with the patient. So let's say somebody goes in and has a severe knee infection and they do a debridement of it and maybe some surgery, and they want to monitor that patient to see if the inflammation is going down. They might do a CRP level every couple days to make sure that the inflammation is coming down in that infection. Interleukins are proteins that they can exert pleiotropic effects on several different target cells. Those are what white cells use to communicate with each other. So you need to have an adequate interleukin level. Okay, you've heard me talk in the last few slides about tube feeding, either IV tube feeding or tube feeding directly into the stomach. I have a nice picture here that kind of gives you an idea of how this works. So it's called total parenteral nutrition, or TPN. This is a widely used means of intense nutritional support for patients who are malnourished or in danger of becoming malnourished. It's used to administer appropriate amounts of carbohydrate, amino acids, lipid solutions, as well as electrolytes, vitamins, minerals, and trace elements. On this picture, we've got parenteral nutrition and total parenteral nutrition. We can have it go directly into the stomach, and sometimes it goes right into the actual vein. The next one, now that we're done with proteins, is carbohydrates. There's a few things that we can determine with carbohydrates when it comes to having TPN therapy. With urine testing, sometimes we see glycosuria during the early phase of TPN, especially in small premature infants. And that might mean that the glucose infusion is too rapid and that the glucose is spilling over into the kidneys. I have a star splash down here at the bottom. What is the renal threshold for glucose? Well, once that blood level gets over about 180 milligrams per deciliter, it starts showing up in the urine. We also see glucose in the urine of small infants after glucose tolerance has been established, however, might indicate respiratory disease, sepsis, or cardiovascular changes. So in stressful situations, we may see it in the urine as well. We also have tests to monitor electrolyte disturbances during TPN. Sometimes children getting TPN can have sodium issues. We can see this is not exactly a TPN issue, but hyperkalemia is a common problem in children when we get the heel stick. In hyperchloremia, metabolic acidosis is a problem when amino acid solutions are used. So, all in all, what you need to know from this is that TPN needs to be monitored very carefully to make sure these levels are not being detrimental to the patient. All right, moving on from the macronutrients to the micronutrients. Vitamins. There's a wide range of functions in biological tissue for vitamins. They serve as cofactors in many enzymatic reactions. We need them to build tissues and things like that. So we're going to go through each of the vitamins and say what they do and give you both the vitamer and the vitamin name. So here's some common deficiency states. These are ones I highly recommend that you know. Scurvy is a deficiency of vitamin C. Rickets, a deficiency of vitamin D. Beriberi, which is a nervous system disorder, can be caused from a deficiency of thiamine. Pellagra, deficiency in niacin. Night blindness, vitamin A. Megaloblastic anemia, which you should know from hematology, can be a deficiency in folic acid. And then we have two general terms that have to go with a calorie deficiency, and they're different. Marasmus is a calorie deficiency where you have adequate protein intake. I think of the person with like maybe doing the Atkins diet but not eating enough, but just eating pure protein. Kwashiorkor is actually a calorie and protein deficiency. I think of when you see the third world countries and they're eating little bowls of porridge and they're very emaciated. That would be more of a kwashiorkor. They're not getting protein and they're not getting calories. Marasmus you might see more in the United States for someone trying to do some crazy high protein diet. Okay, so with vitamins, there are variabilities in clinical expression of vitamin abnormalities. We can have this happen from having differences in the specific cause, degree, and duration of vitamin inadequacy. So you could probably go a week without having a lot of selenium in your diet and be okay. It just depends on how long it's been. We can have a presence of nutritional insufficiencies, and we can also have increased demands. Pregnancy, infections, and cancer can use up those vitamins faster. To diagnose somebody with a vitamin deficiency, we have to look at their dietary history, do a physical exam, and look at laboratory data. There are two categories of vitamins that you need to be familiar with. First one is the fat-soluble vitamins. Pretty much everything else is water-soluble. Okay? It is important to know that the fat-soluble vitamins are only absorbed through your intestines into your bloodstream when fat is present in the diet. So fat is not necessarily a bad thing. And I always think of my grandma storing everything in her attic. And bless her heart, she's dead now, but she was a very large lady. She was very fat. And she put everything in her attic. A-D-E-K. I know it's not spelled like A-T-T-I-C like an attic, but A-D-E-K looks like attic. So those are the fat-soluble vitamins. I always make that connection. If it helps you, go with it. The rest of them are usually water-soluble. So if you know the fat-soluble, you're going to be good with knowing the water-soluble. So here is the difference between the vitamins and the vitamers. The vitamin have the names that you think of when you go to take a vitamin off the shelf or a multivitamin, vitamin A, vitamin B, especially you look at a box of whole grain total, all the vitamins they have listed on the side. That's the vitamin name. You have to know the vitamin name, but you need to know the vitamer that goes with it. The vitamer is the actual name. Now I'm going to run through these and try to help you come up with ways to memorize them. You may think I'm absolutely ridiculous, and that's fine. If you don't like the way I memorize it, you can come up with something else. But I'll tell you how I memorize these. All right, vitamin A, also known as retinol. Okay, just go with the retinol. I know there's a lot of other words there, but if you know retinol, you're doing very well. Vitamin A helps with night blindness, or you won't have night blindness if you have enough vitamin A. I think sight is first and foremost the most important sense. So vitamin A, sight is very important. You have retinas in your eyes. Okay, retinol, vitamin A. Vitamin B1, thiamine, Okay, I don't really know how you want to memorize that one. I don't have a good one, but thiamine is vitamin B1. Vitamin B2 is riboflavin. I see, this is how my students help me. Ribs have two flavors, honey and barbecue. So there's your two flavors, honey and barbecue, vitamin B2. Vitamin B3 is niacin. I always look at nia as 3 letters and sin as 3 letters. So nia, sin, B3. Vitamin B5 is pantothenic acid. To me, panto looks like pento. Pento means 5. Pentagon has 5 sides. So panto, pento, very similar. Vitamin B6 is pyridoxine. When I think of pyra, I think of like pyromaniac, someone that starts fires. I think 6-year-old little boys like to play with lighters, so they like to start fires. Vitamin B7, I have a 7-year-old little boy, and biotin to me reminds me of bionic men. So my 7-year-old likes to play with bionic men, so I have biotin on that one. Vitamin B9, folic acid has 9 letters in it. Okay, so you need vitamin B10. B9 is called folic acid. Vitamin B12 has a lot of letters, cyanocobalamin. While that's not exactly 12 letters, it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. It's 14 letters. We'll pretend it's 12. Has a lot of letters. So cyanocobalamin has a lot of letters. So does B12. 12 would be a lot of letters. Vitamin C, ascorbic acid. It's got that C in it, ascorbic. Vitamin D, ergocalciferol. I don't have a good one for that. Vitamin E are tocopherols. I don't have a good one for that. So if you think of something, let me know. And vitamin K, phylloquinone. I always think my kids love phyllo dough. Anything that's wrapped and baked in that crunchy, wonderful phyllo dough, which is spelt this way, Phyllo. And K is like kid. Okay, so kids love phyllo dough. So that's how I keep those memorized. I just have to memorize the ergocalciferol, tocopherols, and things like that. But some of the other ones I memorize by association. It's all I can do. Sometimes you got to do whatever you can to try to memorize things. All right, so now we're going to run through each of those vitamins and figure out what the heck they do. So why do we need to take these? First set are the fat solubles that we'll go through. Again, remember you have to eat fat to be able to absorb these. So if you have a fat malabsorption issue in your gut, you're going to have a hard time absorbing these vitamins and you'll be deficient. So vitamin A, which is known as retinol, we get it from animal products, pigmented fruits and vegetables, and it comes from beta carotene. Its function is for vision, cellular differentiation, growth, reproduction, and immune system function. But if you don't get enough of it, you have problems with night blindness and total blindness. Vitamin E, also called tocopherol, we find it in vegetable oils, leafy vegetables, egg yolks, and legumes, which are also beans. The function is it acts as an antioxidant to strengthen cell membranes. The effect of a deficiency is hemolytic anemia. You may have heard of people taking those little vitamin E tablets, breaking them open and rubbing them on their skin because it helps strengthen the skin cells too. Next fat-soluble vitamin is vitamin D. Now we talk about this as being a hormone, but it requires sunlight. We need fortified milk to get the vitamin D to turn it into the D3. Butter, egg yolks, liver, sardines, herring, tuna, salmon, yum. Functions include proper skeleton function and mineral homeostasis to maintain those mineral levels, especially calcium. And the effects of deficiency would be rickets or osteomalacia. Rickets is more in children, osteomalacia is more of adults. Vitamin K, there's our phylloquinone. We get this from cabbage, cauliflower, spinach, pork, liver, and soybeans. It forms prothrombin and 5 other coagulation proteins. A lot of babies have immature livers and this is where vitamin K is made. So sometimes we give babies a shot of vitamin K the first day of birth to make sure that they have the proper coagulation proteins. Effect of the deficiency could be bleeding, bleeding out, which would be unfortunate in a baby. Now we'll move on to the water-soluble vitamins. Thiamine is vitamin B1. We get that from yeasts, liver, oatmeal, brown rice, and whole grain flour. It's a coenzyme in decarboxylation reactions, which happen in the nervous system especially, so we find a deficiency. We end up with beriberi, which is a nervous system disorder. Riboflavin, vitamin B2. Remember, two flavors in ribs, punny and barbecue. The sources include milk, liver, eggs, meat, and leafy vegetables. It is actually a component of two coenzymes catalyzing oxidation reduction reactions. So because of that, if we have a deficiency, we would have reduced glutathione reductase activity, which can cause problems, especially in the red blood cells and such. Pyridoxine, vitamin B6. Remember those 6-year-old boys pyromaniacs, like to play with fire? The sources include meat, poultry, fish, potatoes, and vegetables. It balances sodium and potassium and promotes red blood cell production. If we don't get enough of it, we can have hyperhomocystinemia, seizures, and irritability. Niacin, vitamin B3. This is good for the conversion of dietary tryptophan. That's the stuff that you hear of that turkey has that makes you so tired. It's also a component of two coenzymes known as NAD and NADP, and a deficiency will lead to pellagra, which is kind of a skin/nervous system disorder. Folate or folic acid, same thing, known as vitamin B9, we find in green leafy vegetables, fruit, organ meats, and yeasts. It is a coenzyme, and if we don't get enough B9, we can end up with megaloblastic anemia. We can also get megaloblastic anemia from a deficiency of vitamin B12, which is our next one, known as cobalamin. Sources here would be meat, eggs, and milk. The function is it's a coenzyme for hematopoiesis and fatty acid metabolism. It requires intrinsic factors secreted by the stomach. And active forms are methylcobalamin and deoxyadenosocobalamin. The deficiency, again, megaloblastic anemia. Next one, biotin or vitamin B7. Find it in numerous foods, so it's really not hard to get sufficient B7, which is probably why we don't hear people say, I'm vitamin B7 deficient. It's a coenzyme for the transport of carboxyl units in tissue. It plays a key role in gluconeogenesis, which is the formation of new glucose from non-carbohydrate sources, lipogenesis, and fatty acid synthesis. A deficiency can cause decreased appetite and growth. Vitamin B5, pantothenic acid, is found in liver, other organ meats, milk, eggs, peanuts, legumes, which are beans, mushrooms, salmon, and whole grains. It's a growth factor, and that one, since you find it in so many things, it's very rare to be deficient of it. Next one, vitamin C or ascorbic acid, we find in fruits and vegetables. Its function is the formation and stabilization of collagen, increases absorption of certain minerals such as iron, and a deficiency causes scurvy. Make sure you check out my course announcement with the scurvy video. Carnitine sources include meat, poultry, fish, and dairy products. Its function is to facilitate the entry of long-chain fatty acids into mitochondria for energy in your cells. So therefore, if you don't get enough of that, you would have muscle weakness and fatigue because you need the energy to make those cells work. In addition to the vitamins, there's other minerals that we need to monitor, especially when they're receiving total parenteral nutrition. We need to look for deficiencies in excess of calcium, phosphorus, and magnesium. Calcium and phosphorus are closely related in the key role of bone mineralization. Remember, they have the inverse relationship. Calcium's high, phosphorus is low, and vice versa. And here's a review that we've talked about a few hundred times. Calcium is present in two forms, protein-bound and ionized. Remember, ionized is the best way to determine the calcium status in a patient. It's also important that intracellular phosphorus is necessary to promote protein synthesis and other cellular functions as well. Some of the other ones, copper. This is a key component of many enzymes. If you are deficient, we see pallor, which is kind of a paleness, decreased pigmentation, vein enlargement, rashes resembling seborrheic dermatitis, and if it's toxic, we have that Wilson's disease and those Kaiser-Fleischer rings in the cornea. We can also see hepatitis, fibrosis, and cirrhosis if there's too much copper. Zinc is a very important component of greater than 200 enzymes. It's important for protein synthesis, gene expression, transport processes, and the immunological reactions. What is the thing that you see on TV in the fall when everyone's got the cold and flu season? Zicam or Zinc C. You try to get you to take more zinc to help with that immune system. If you don't get enough, you can have diarrhea, perioral dermatitis, alopecia, which is hair loss. Alkaline phosphatase can also be greatly affected. And if you have toxicity, it can cause a hemolytic anemia or a zinc toxicosis. Iron, you've learned about that in hematology and in our trace element chapter. But this plays a key role in respiration and the transfer of oxygen. You know it's found inside the red cells. Deficiency would cause anemia, restless leg syndrome, and too much iron can cause damage to the heart, liver, and even cause death. Selenium, the function, it's a cofactor to the enzyme glutathione peroxidase, which is involved in neutralizing hydrogen peroxide formed in cells. If you have too much of that hydrogen peroxide formed in your cell, it can cause damage to the DNA, etc. Selenium helps avoid that. So if you have a deficiency, it can cause cardiovascular disease, cancer, low sperm motility, and miscarriages. And if you have too much, it would cause fatigue, irritability, loss of hair and nails, vomiting, nerve damage, skin rashes, and brittle bones. That concludes my section on nutrition.